right, everybody. Good morning. I think it's still morning in all the relevant time zones. Welcome to the 2023 Symposium on Substance Use Research. This is the panel discussion about the health impacts of state policies, drug decriminalization, and service access. So a lot going on there. Should be a great panel. So I am Dr. Brandon Del Pozo. I'm an assistant professor of medicine and public health at Brown University. I research the intersection of public health and public safety as it relates to substance use and overdose. I'll be the moderator today, and I'm thrilled to be here. So just a few notes before we begin and introduce folks and get going. The first thing to remember is this session is being recorded. If you are a registrant, you'll get an email, and we'll post on social media when the recordings are going to be available. Also, this session is a webinar, so attendees will be muted. Muted verbally, not in spirit. If you have a question, the Q&A function will allow you to submit it, and we'll try to answer them as time allows. So you'll see at the bottom of your screen a little Q&A icon. If you submit a question there, time permitting, we'll definitely do all we can to get to it. Anyway, so I'm excited to introduce today's speakers. We have three experts joining us today across a range of disciplines that will help us better understand things about decriminalization, state policies, federal stuff, service access, all of it. One is Dr. Roberto Abadi, Dr. Sheila Vicaria, and Dr. Steve Davis. So I'll take a moment to introduce them. Dr. Abadi, could you go ahead?
Yeah, Roberto Abadi. I'm a medical anthropologist, and I'm at the University of Nebraska-Lincoln, and my work focuses on documenting the effects of the war on drugs, and in particular, the effects of the war on drugs on access to treatments.
Thanks. Great to have you. Dr. Vicaria.
Hi, my name is Sheila Vicaria. My pronouns are she, her. I'm the Deputy Director of the Department of Research and Academic Engagement at the Drug Policy Alliance. For those who are not familiar, the Drug Policy Alliance is the leading national advocacy organization fighting to end the war on drugs. In my role at the Drug Policy Alliance, I first try to help ensure that DPA's policy advocacy agenda is informed and responds to the best available research and evidence. But secondly, another big part of my role is working directly with researchers and academics to find ways to bridge the divide between the ivory tower and how decisions are made in terms of policy, but also helping to build their skills in speaking to journalists and the media about their work.
Great, thanks. It's great to have you. Dr. Davis.
Good morning. I'm Steve Davis, and I'm an associate professor in the Department of Health Policy, Management, and Leadership here at West Virginia University. My work has examined the implementation of needle exchange programs for the prevention of hepatitis C virus and other infectious diseases in rural Appalachia, in particular West Virginia. I've particularly interested in structural barriers as well as facilitators to implementing what we know works, in particular needle exchange programs and other harm reduction strategies. So thank you very much for having me today.
Yeah, great, Dr. Davis. I have a question down the line for you about syringe service programs, so get ready. I guess the first question I'd like to actually pose directly to Dr. Vicaria, but then everybody feel free to jump in. I just know the DPA is really at the forefront of thinking about this. A lot of the substance use related decriminalization and reform policies center equity and justice. They look at issues of race, of gender, of sexuality. And so they're posed as ways to pursue justice. What promise do they also hold for improving health outcomes? But the question I'm asking is how are issues of equity and justice related to issues of health? And how do these decrim efforts try to get at both?
Okay. It's a big series of questions. I think first and foremost, we have to acknowledge that the criminalization of drug use and the apparatus of policing have been used as a tool of social control for communities of color, new immigrants, for low-income communities, and people deemed other. And so by its design, these systems and structures have been used to target these communities. And then when we look at the root of our war on drugs specifically, the ways in which our approach to criminalization, rather than regulation or other models of dealing with the public health needs of people who use drugs, also weaponized xenophobic and racist tropes and also tropes about low-income whites and disposable whites. to advance the criminalization of drugs and drug use. And so by design, our war on drugs has also been a method and a tool to target communities of color and low-income communities. So in many ways, our war on drugs and the criminalization of disproportionately brown and Black people and low-income people is our war on drugs working as designed. And so by promoting decriminalization, we are trying to remove drug offenses from the toolbox or the toolkit that our legal enforcement apparatus uses to target those communities. And so by removing that premise for engaging with communities of color and low-income white communities as well, we are attempting to build equity into the system. But we have to acknowledge that policy change alone is not going to be enough to reduce disparities in arrest because, as I said from the beginning, policing in and of itself also deeply targets certain communities. So by removing drug offenses from the possible qualifying charges for which to target communities of color, we are taking one tool out, yet the practices can still just instead replace them with other charges that they can often use to target these communities. But our intention is to have an impact in reducing the targeting of these communities. And then when we think about reducing health disparities among these communities, we have to acknowledge that criminalization is bad for people's health. Contact with the criminal legal system, including arrest and incarceration, can disrupt your access to services in the community that you were engaging in and can actually put you at worst risk for health. We know that access to clean water, heating, air conditioning, healthy foods, adequate health care, and medication, evidence-based medications like buprenorphine and methadone are abysmal in our criminal legal system. And for those who receive alternatives to incarceration, such as probation, parole, or drug courts, they still do not have access to those evidence-based services. So we know that when we see racial disparities in overdose death rates right now as one metric, criminalization of these communities and contact with the criminal legal system could be driving some of those harms. I hope I answered all the questions.
No, you did. It was really compelling. It made me say maybe I should have asked a shorter question. Does anyone listen? The intersection of health and justice is what drew me to this field. Does anyone want to add anything to that?
Yeah, I want to say just one thing about the war on drugs. The war on drugs is not a war on drugs. It's a war on people. You cannot have a war against a leaf like cocaine, comes from the coca leaf. You cannot have a war on a bulb like heroin, comes from a flower on a bulb. It's always a war on people cultivating, harvesting, selling, buying, and using, and their communities. And it's really perversive. I really appreciate Valkyria's take on the war on drugs in the sense that you can decriminalize certain practices, but the repressive system can really find other ways of targeting the same population. Very hard, very serious to remove. I think we have to think very carefully about the ending the war on drugs and what it really means and how to do it and what's possible and what's doable, because it's much harder than it seems.
No, it's very interesting to think that the war on drugs is not only unwinnable and wrongheaded, but fundamentally a misnomer. So, I mean, there are, promising steps, right? So we have some of the more sweeping ones, for example, the state level decriminalization of possession in Oregon. In New York City for a few years now, we've had the officially sanctioned operation of overdose prevention centers known as safer consumption sites. So these are still relatively recent. We're talking about years, not decades, right? There's a lot of clamor to say, what are the impacts? Is this working? Look, it's not working. Let's stop it. So in your experience as researchers and policy folks, what do you think is reasonable to say as a time frame for understanding the results, right? And what kind of lessons can we pass along, if any, so far from what we've seen about these Decrim and OPC efforts? That's for anyone.
Well, I think that research often moves quite slowly. We can all agree on that. But I have become very recently aware of some promising results out of Oregon and Washington. from NYU, I believe, collaborated with the CDC. This was just released a couple of studies in late September, where they actually found that decriminalization in Oregon and Washington State did not contribute to overdose deaths. There was no increase in overdose deaths, and equally importantly, they did not see any type of increase in arrests for violent crimes, right? Because that's one of the concerns is, we're going to decriminalize this, crime's going to go up. What they did see was a decrease in arrests for having drugs or substances. And so I think that's quite promising. That's some of the early things I've seen coming out, but obviously it takes a long time, especially if we want to conduct our longitudinal studies moving forward in time, et cetera. But that's some of the most promising things I've seen so far.
I'm happy to jump in. So we at the Drug Policy Alliance were the ones to work very closely with Oregonians to introduce the ballot measure to decriminalize the personal possession of drugs in Oregon. And I just wanted to jump in that, yes, absolutely. The NYU researchers who published their findings found that there was that the implementation of Oregon's Measure 110 did not lead to any more significant increases in overdose deaths. But we have to acknowledge that overdose deaths did go up in Oregon, as they did in many other states around the country. Their analyses, though, did not find that compared to synthetic controls, that overdose deaths went up any more dramatically after the implementation of Measure 110. So we have to kind of also just be mindful of how we talk about the research, right? And I think that talking about overdose death rates and decriminalization is an interesting way to talk about potential impacts of policy change on overdose deaths. But we have to acknowledge that our drug overdose deaths are driven by our drug supply, an issue that is not addressed by the simple decriminalization of drug possession alone. And it gets at some of what I had been talking about earlier, how criminalization of users increases their risk of overdose, oftentimes because of their own disruptions in access to the supply or their access to treatment or other supports. But we just have to also acknowledge that, like, the ways in which we measure the metrics of success of Measure 110 have to be related to what decriminalization can do, right? So I was part of a research team that released a paper just a few months ago as well about how, first and foremost, we were able to show statistically significant reductions in drug arrests following the implementation of Measure 110 beyond the COVID-related reductions that were happening in that state. And so again, we have to remember when we measure the metrics, when we use metrics to measure 110, we have to use the metrics that actually match the intervention. And expanding access and funding to treatment was another big part of what we wanted to do with Measure 110. And part of that was allocating over $300 million in historic funding towards building out the treatment, recovery, harm reduction, and health service infrastructure of the state. And the ripple effect of those changes is going to be taking time for us to see in terms of the impacts on those communities and what those services were able to deliver. So part of it is that we never asked criminalization for immediate results to show us it was working, yet we are holding these policy interventions in which we are changing our approach to these very rapid response kind of outcomes and metrics that is supposed to somehow solve things, and that the knee-jerk response for some opponents is to return back to the status quo, which was also killing and harming people and not investing in the infrastructure whatsoever.
I think that's very thoughtful. I think one of the takeaways from this is that a lot of the analyses of Oregon look at the results with decriminalization as the primary intervention of concern, rather than looking at when fentanyl really saturated the supply in Oregon. I know some colleagues who are attendees and I are actually trying to tease that apart, so stay tuned. But it's a great point, Dr. Vicario, that there is no evidentiary standard for criminalization, and yet we want an immediate, very rigorous evidentiary evaluation of decriminalization. Yeah, which it seems like it's very lopsided. So in 2021, New York State decriminalized the possession of syringes. They're not alone, right? They joined a host of states such as Rhode Island and Vermont, but it remains a misdemeanor crime to possess a syringe in many states. And in Indiana, simple syringe possession is a felony. So some policymakers argue, and this was when they shut down the syringe service program in Marion County, Indiana, not too long ago. They said, listen, HIV is under control. These health concerns aren't as compelling as they used to be. It's best to not have these SSPs out there. We're going to shut them down. So, I mean, are policymakers and researchers paying enough attention to this issue? And how can they bring greater clarity to it, right? I think Dr. Davis, this has your name written all over it.
Yeah, that's a big issue. So a couple of things. One, it may be erroneous to conclude that HIV is under control because you don't know if everyone is being tested, right? We know that some people who inject drugs are homeless. They may not have access to testing. So we may not know what the exact rate is, okay, or what's going on. But in terms of the policy status of the legality of syringes or possessing syringes without a prescription, what I have seen in my own work and what we have seen is this directly contributes to sharing of syringes. And the number one way that you get hepatitis C, HIV as well, is syringe sharing. And what I've seen and what a lot of us have seen is that fear of arrest is driving syringe sharing. Okay, a lot of the folks I talked with that attended these exchanges were like, I don't want to discard needle, syringe, but if I get caught again, I'm going to go away for a long time. And so you really saw in a lot of the folks I talked with this battle with, well, I don't want to discard it. I don't want to reuse a syringe, but at the same time, if I get caught with one, I'm going away for a long time. Or I don't know, one officer might say, yeah, it's fine. The other officer might say, no, it's not fine. And there was just this battle and it was all related to the legality. And in the state of West Virginia, there was nothing to say that you couldn't have a syringe without a prescription. But localities, depending on what city you were in, might have a different ordinance. And so you don't know. And there's this confusion. It contributed to syringe sharing, which in turn contributed to, again, spread of infectious disease. And we won't even get into, of course, some of the other policies that have restricted syringe access programs in general, in West Virginia in particularly, but that in turn all restricts the availability of clean syringes. But fear of arrest is a huge driver that I saw that really contributed to syringe sharing and in turn, the spread of infectious diseases. And so I really think it is a misnomer to conclude that it's all under control. We don't need these programs.
Yeah, no, and I certainly don't think it's under control, right? I was just posing that.
Right.
I mean, in Indianapolis, they apparently do. I'm sorry, I interrupted one of the presenters.
No, I just jump in, Brian, and I wanted to say this criminalization of syringe possession is part of this magical thinking of politicians and in general, the magical thinking of the war on drugs. If we take the syringes away from people, people wouldn't shoot drugs. Yes, sure, right? No, they're gonna share syringes. They're gonna use dirty syringes. They're gonna increase risk of drug-related harms. If we take the drug supply away, well, try that with the epidemic of fentanyl. Fentanyl demonstrates the futility of the war on drugs, the failure of the war on drugs. They try to cut the supply. They blame China, they blame Mexico, they do a lot of things. Nothing works, of course. So it's kind of the same kind of magical ideology behind the war on drugs. I said at the beginning, the war on drugs is pervasive, it's on everything. Even in a measure like criminalization, syringe possession. That's why it's so hard to tackle.
Yeah, no, thank you. So we'll see, I guess we'll see how things progress. So
and can I jump in for 1 second? Yeah. And so, I mean, I think the other thing that I think is really important to name is that even saying that syringes are legal in a jurisdiction doesn't necessarily mean they are accessible, available, distributed in ways that are meaningful to people who need them, are needs-based rather than one-to-one based. and that the equipment is the supplies that people want. We look at the latest CDC HIV outbreaks that were driven by injections-related harms, and they were in Indiana and in West Virginia, a state that can tout that they have legalized syringe access, right? But what happened in these jurisdictions where the outbreaks happened, for instance, in Morgantown and Huntington, was the sheriff said, we need proof, we need names, we need proof that these people were referred to treatment. They can only get retractable syringes. There can only be a one-to-one exchange. So yes, criminalization of syringes, of course, is going to make it challenging in a state where you cannot legally operate a program, where people are afraid of getting arrested. But I would also just like to note that even states that have so-called legal access to syringes or legally operated syringe exchange programs, when they are put under such tight constraints and when participants fear for their confidentiality, their privacy, more surveillance, and when they're not getting the supplies that they need at the scale in which they need, we also are going to see a lot of the same problems emerge.
No, thanks. I think one of the themes that emerge from some of these responses is the difference, number one, between the law on the books and the law on the streets, right? Between what the statute might be and how people live or experience the law, or what other charges might be used to make up for the lack of a syringe charge. And then there's a difference between what's legal and what's funded, right? And what's legal and what's acceptable and feasible, which I think Dr. Vaccaro did a great job of reminding us about. So, moving along then, in November of 2021, New York City, as we mentioned, opened the first two officially sanctioned, government-sanctioned overdose prevention centers. The prior mayor de Blasio, started them. He was supportive. Mayor Eric Adams has said time and time again he supports them and he would like to see them expanded. So you have that going on in New York now for about 2 years. And then you have right next door in Pennsylvania, the city of Philadelphia preemptively banning the opening of any overdose prevention center after a few years ago being one of the cities poised to be the first to open one. I mean, I guess my question is like what's going on here, right? What kind of research and what kind of policy work can explain these divergent approaches and bring some, I'll be candid, bring some sanity to the seesaw going on?
I mean, I think it really goes back to whether you view this as a medical problem or a criminal problem, and how far is too far, right? For instance, in West Virginia, needle exchange syringe access programs are not viewed very favorably currently. And what Sheila was talking about, we still legally have syringe access, but the restrictions in place are not evidence-based. One-to-one exchange versus needs-based, having to show ID, all of these things have just really limited policy solutions, really not solutions, that have limited the ability of these programs to operate as they should, evidence-based, and how they've been shown to work in Europe. And so to me, it really does go back to, do you view this as a medical problem, a brain disease, or a criminal problem? And if you view it as a criminal problem, then the approach is jail. The approach is lock them up. Okay. And again, getting back to West Virginia, giving out needles or syringes is no longer viewed very favorably. However, peer recovery coaches are, right? Because that's something, the emphasis is to get people in treatment, right? And that's one of the problems with syringe access programs, especially with law enforcement, is they don't understand this is about ultimately getting people in treatment. It's not just about giving out syringes. And so again, I think that the difference you see in policies in states really is related and rooted in, is this a medical problem or is it a criminal problem?
I don't think this is a problem that research can solve. And if there is research that can solve this, it's research in attitude change, in compassion and destigmatization. It's research in understanding how people perceive their property values above the values of their neighbors and their community members. It's funny, I work in the Department of Research and Academic Engagement. I'm always talking about evidence-informed policy, but what has more evidence than overdose prevention centers and syringe exchange programs when we think about global evidence for interventions that save lives? Methadone. We could talk about that, right? And so I think, while it's comfortable for us to think about ways to intellectually provide knowledge and information and resources to people we think are making decisions based on a deficiency of information, is well-intentioned. But I do think that really a lot of these decisions are based on a deficiency of compassion and understanding. And those are far more complex for us to be able to talk about. And we could NIDA could fund millions and millions of dollars worth of research in harm reduction. And I hope to see that. They're allocating more money to do so right now, and arguably way too late. But at a certain point, we have to acknowledge that we have to talk about a mindset shift. We have to talk about an emotional shift. We have to talk about a culture shift, but we also have to help people really understand what's happening on our streets right now. COVID laid bare structural and social inequities and challenges and disinvestment in ways that people still have not wrapped their heads around. And it's very easy to turn this into individualized problems, moral failings, people not pulling themselves up by their bootstraps, and seeing the most visible marginalized person as a representative of a larger, broader group. And I think there's more to be said and done about kind of developing that analysis and that consciousness among people, because that is part of why it's okay to dispose of people. It's okay to let some people die. They made these choices. And that kind of mentality is really fueling a lot of what we're seeing.
Roberto, would you like to add anything?
Totally agree. Totally agree. The war on drugs is it's sinister because it shapes not just practices, but minds and mentalities and way of thinking about things. The idea that if you cut things, syringes, access to safe injection places, access to drugs, the problem will be magically solved. It's magical. I'm an anthropologist. There's studies about magic and primitive thinking. It's a very, very primitive way of thinking about things. It's very irrational way of approaching a problem, but it's a very popular and compelling way of framing issues, because at some level, it makes sense that if people don't have a place to inject, probably they won't inject. They're going to find another place, an unsafe place, an unsafe drug supply, an unsafe injection equipment kit. But at some point, it's almost like so compelling because it's a lie. There's no evidence for this, but it's a lie that's been repeated so many times in so many different forms and by people in authority positions that makes a lie convincing and compelling. I want to say something about decriminalization that perhaps I should have said at the beginning. It's the framework of decriminalization, it's great, but the ideas of and the push for decriminalization comes usually from the East Coast and the West Coast. In Nebraska, recreational marijuana is not legal. In Puerto Rico, recreational marijuana is not legal. In many places, we still have a long way to go to do very basic stuff that it's just recognizing what people are already doing. People in college towns all over the country are treating marijuana like legal and recreational, but many states are very, very far behind. So I just wanted to say, yeah, decriminalization is really good, but in discussing decriminalization and its effects, we have to still think places where we are at square one in terms of the war on drugs and in square one in the war against decriminalization.
I think this broaches for researchers, number one, the point that in Europe, there is research on the evolving attitudes toward overdose prevention centers in the communities they're located in, how a lot of the attitudes moderate over time as they realize that, the effects are not as severe or disruptive as people originally intended. And then you see, I think, sort of a pendulum in the States where people have varying levels of patience and willingness, and then suddenly they're pushing back. And I know that might not be at the individual level. Maybe I'm making generalizations about what we read in the news, but I think the point that we need research into not the science of saving lives, because it's fairly clear, very clear, but the science, the behavioral science of why people do or don't accept these interventions, and then how their opinions and feelings moderate over time. One research-related plug, my colleagues and I have a paper coming out about the crime and disorder effects of the 2 overdose prevention centers in New York City. It'll be out in JAMA Open on Monday. Everything is embargoed until then, but if you're interested in it, around noon on Monday, it should be out there. So you can wait with bated breath. So I do want to bring this a little bit. I'll ask one more specific policy related question and then talk more about policy related research and research to practice and research to advocacy. Well, maybe one or two. So one of the approaches at the state level for bringing MOUD into carceral settings is the Americans with Disabilities Act. A lot of litigation that argues folks with substance use disorders have a disability, and to not treat that disability is violating the ADA. That's worked in some states. Do you think that's a viable strategy? Do you think that should be a 50-state strategy? What are the research questions that might shore that up? If you have any opinions on that, I think the audience would love to hear it. I'll just point at Steve, Dr. Davis, and
Sure. Yeah, it's obviously going to be state specific. And I think to go back to what we discussed about it really being related to attitudes, I don't know how easy it's going to be to overcome existing attitudes, especially in conservative states and red states like West Virginia, that this is a moral failing, right? And that it's not a brain disease, it's a moral failing. And so I think that, as I would like to say, we have other things we're dealing with right now. I don't know that that would be at the top of the agenda, at least in West Virginia, for trying to move the needle on getting it into jails. I mean, obviously what we've seen, like everywhere else, is the tragic fatalities that happen when individuals who are incarcerated then finally get released. They lose their tolerance, they use, and that's it. I think related to the attitude issue is that there's a misunderstanding of the reality of addiction. That addiction, for most people, relapse is a fundamental part of it. And so I think that, like, you talk about MOUs and you talk about Europe, you look at preventing hepatitis C and HIV, the best strategy they saw was combining needle exchange with MOUD. But that would be a non-starter over here. Why? Well, if you're on MOUD, you shouldn't be using. Whereas they take the approach that, relapse is reality of addiction. And so if you are going to use again, have a clean needle available.
Dr. Abadi, did you want to say something? I'm happy to jump in as well.
I just wonder if a jail is the best place. There's a lot of problems with methadone in particular treatment, right? In terms of inequalities, but also the controlling, alienating way in which methadone is provided in the US. And I wonder if the jail is the best place to do this. And if it's not, I agree that inmates have a right to treatment, and not just for methadone or Suboxone. In general, good quality healthcare treatment. But if the jail is not the best spot, how do you treat people that are incarcerated for their medication opioid use disorder?
So can I add one last thought to this? So I think that what you pose is a very important question for us to answer in terms of how do we increase access to evidence-based treatments that we know reduce the overdose risk by over 50% among people who are able to take them at levels that are clinically meaningful and personally meaningful to them. And, talking about using the ADA as a tool is an interesting one. The premise of advancing a medicalization model, a disease model of addiction, a brain disease model of addiction, for instance, or a disability health disability model for understanding people with substance use disorder. And I understand from Dr. Davis that he is a proponent of the brain disease model. And what I would say is that we're living at this very interesting moment, right? Where drug use of certain kinds that are unsanctioned or by undesirable people or that is criminalized is seen as a moral question, right? These are immoral people who chose to consume a bad substance, and they are bad by nature because of what they consume, right? Like that kind of feedback loop, right? And then we we think about, centuries down the line, the criminal legal apparatus developing and then institutionalizing and criminalizing things that were deemed bad and people who were deemed bad now as criminals, right? and aligning that, putting that same disposability and undesirability and marginalization upon now the criminal, right? And then people who use drugs being now that in that category. And these proponents of medicalization who want to say that substance use disorder is a mental health or a physical health issue, proponents of the brain disease who believe that it is a chronic relapsing brain disease. Again, many of them, well-intentioned, say that medicalizing addiction is a way towards destigmatization, right? Living in a world where it's seen as morally wrong, seen as a crime, maybe by making it a sickness, we can help destigmatize and increase access to services. But I would argue that there are trade-offs in using medicalization, and that when we medicalize substance use, that we have to be ready for the ramifications, right? So there's ways that we can use medicalization to help, perhaps in expanding access to medications that we know work. But the trade-offs is that when we feed into a narrative that these are people with diseased brains, we then can also feed into narratives that they are incapable of having free will, that they aren't capable of they don't have functioning prefrontal cortexes, or they can't make good decisions for themselves. And proponents of the disease model are proponents of coercive treatment methods and involuntary commitment as well, because these addicts don't know what's good for them. And so I would argue that as someone who's used medicalization oftentimes in situations just like this, to say we need to increase access, it's an alternative to criminalization, we have to always acknowledge that medicalization is going to come with trade-offs, but criminalization is always going to win. And that's also part of the debate that we are seeing here.
I want to say something
Go ahead.
about medicalization and the dangers of medicalization. And in America, in a country where 30, 40 million people don't have access to health care, when if you don't pay, you don't have it. There's very serious inequalities and disparities related to access to a lot of things that people need to get treated, to get better, to have a future. So we are amplifying or reproducing inequalities if we don't think carefully about these things. So yeah, medicalization sounds a lot better than repression and prohibition, but it shouldn't be. We have to think also carefully about what we are asking for and wishing for.
No, thanks for bringing that up. As a person who sees this from the outside and doesn't directly research it, it did strike me that the Americans with Disabilities Act is a distinctly medicalized approach. And I know that it's still, that's contestable, right? And a double-edged sword. So I'm going to combine the last two bullet points I have on my list with the questions I was thinking of. And I'll put it out there, then hopefully we can go to some questions from the audience. And by the way, I see there's a question from the audience. So one, what if we're talking researcher to researcher predominantly in this panel, what should the research, what does a good, in your opinion, this is a two-part question. One, what does a good policy-informed research agenda look like, right? If you're at the DPA, if you're living in Nebraska, in the Midwest, if you're in West Virginia, what does a good policy-informed research agenda look like? And then how do researchers engage with policy folks in a meaningful way? If you have a success story or an observation, we'd love to hear it. So that's part A and B for you folks.
I can definitely take part B, but I'll hold off in case anybody wants to address part A.
Dr. Abadi, do you want to jump in first?
I just want to say something. I'm kind of frustrated. I wrote papers and with, you have to end with policy recommendations, and I did that. But I almost never believe in that section because we know what works. People who inject drugs need clean needles, a safe space to inject. They need more than that. And they always say housing and jobs, something to keep their minds off the drugs, something that gives them future. They need a viable life and a viable future. These are not technically complex issues. There's no mystery about what things we need. I think sometimes we make these gestures about, engaging policymakers, but it's a political thing. Those see people as disposable, as worthless, as useless. And fun things, put the money where your mouth is if you are advocating some kind of change. I I know I'm ranting.
I mean, I can answer part one and then pass it along for part two. I mean, I think one of the things that we at DPA are really interested in terms of advancing policy relevant research is uplifting the voices of communities who are impacted by criminalization and who use drugs themselves. A really big effort that we are trying to advance in our network and among researchers that we collaborate with is the meaningful engagement of people who use drugs as collaborators, co-conspirators, as co-investigators, as co-presenters, and co-designers in the studies about issues that affect their lives. The kinds of questions that come top down from a researcher may be intellectual exercises, but really the research that needs to be conducted is about the living and real material conditions of people's lives on the ground and the kinds of correlations and analyses and connections that only they see in terms of how it plays out in the risk environments that they live in and the access to services and the ways in which they face and experience these systems on a day-to-day basis. And so I would say that the most policy relevant research that we can do meaningfully as researchers is research in which we follow the lead of impacted communities and uplift their expertise and help build their research skill sets to become collaborators in research about the conditions that they are living in, because it's they who have, you know, those who are closest to the problems are closest to the solutions. And it's really easy to want to keep doing a study based on what you can imagine when the next time you see an RFP or, you know, a request for funding proposals. But, you know, bringing communities involved in these issues about the kinds of questions they want to ask and the kinds of answers that they propose or believe that they will see will be really, really important.
Yeah, and if we look at success stories, what comes to mind to me is North Carolina. North Carolina in 2016 was one of the first so-called red states. We have to be careful. I mean, we've talked about kind of medical model, brain disease versus moral failing. That's, I think, a manifestation, a reflection of our dichotomous thinking, paradigmatic thinking that we have in the Western world. And so I do want to preface my comments with it's never that simple when we talk about red versus blue and all of that. But in general, it's tend to be observed that Republican states, Republican supermajorities, you will often see the moral failing as manifested in their policy. And so North Carolina in 2016 became the first state with a super Republican majority, deeply red state like West Virginia is, to legalize syringe access programs. And if you look at how they did it, and I think that's pertinent to this discussion and also maybe some of the additional research, they had attitudinal research that perhaps we could conduct. Well, one of the things they did is they got law enforcement on board, because law enforcement is a huge part of all of this. And because law enforcement being on the front lines, they struggle. I talked with police chiefs, I talked with law enforcement. They're like, well, isn't this illegal or is it? You know, what do I do here? Boots on the ground. And what they were able to do is they were able to do some interventions with law enforcement in North Carolina where they got them to understand that, hey, this is a public health issue. And if you're searching a subject and you get stuck, you may reduce your chances of getting HIV or hepatitis C. And that was one way, and I saw that in West Virginia as well when I talked with law enforcement, that if you can make that link, that it could protect them and protect their families, they start to come on board with syringe access programs. The other thing they did, and I don't think this is limited to law enforcement, but just the general public, how do we get the general public to understand that harm reduction, especially syringe access programs, the ultimate goal really still is to get people in treatment? It's just reflecting kind of the Prochaska and DiClemente approach, stages of change, that it may take some time, that people are often thinking about it. And how do we get them to understand, as the CDC has observed, that you're 5 times more likely to actually go to treatment if you attend syringe access programs. And so they were able to do this intervention with law enforcement, get them on board. They got a champion Republican legislator, and of course they did grassroots community efforts as well. And all of this successfully led to legalization of syringe access. And I think the other thing that they did that might be a model for moving forward in trying to get legislators to pass policies that facilitate the implementation of evidence-based solutions that we know work is to, you can always say, well, you may be on the fence about this, but how about you also provide some funding so that we can research the outcomes? right? Because sometimes that can be a mechanism as well with legislators who might be on the fence to say, well, we'll go ahead and put some funding in there to also research some outcomes so that we can come back in X number of years and see if any of your concerns really happened, whatever those may be, whether that be an increase in overdoses, an increase in crime, et cetera. And so North Carolina, I think, was a very compelling example of how we can positively influence policymakers.
Yeah, what I seem to be hearing is there's a lot of valuable knowledge in the communities themselves, and the research has to acknowledge that knowledge rather than say, sorry, we're the researchers, we've got it. I'm also hearing that like basic science about this is pretty settled, that the medications, at least 2 of the 3, are effective. SSPs are effective. So how do we build like human-centered systems that really leverage that?